I don't know how the chilled music is going to go over this conversation, but we'll leave the music on for now, just in case there's a bit of dead air and I need to think about words that I want to say. So I have a few thoughts about this. A friend of mine has sent me an article that we're going to go through as well. I'm not going to go through it in massive amounts of detail, but we are going to try and go over the key points in the article. The article I'll show you here is titled, I had to look that up, I wasn't sure when, this is the article, is Drug Info, Adults and Antipsychotics. So we're going to go through this. It's from Mad in America. I don't know much about them, to be honest with you. I don't know what their reputation is and stuff like that, but it's from a trusted friend, so I assume that it's a decent enough source. So we're going to go through this. However, I'm going to start off the stream with my experience personally with antipsychotic medication. Not just me personally, I have been on antipsychotics and still take a relatively low dose, and that helps me a lot. However, when we start getting into the higher drugged up doses that doctors tend to use, we encounter multiple different symptoms, which on higher doses it's like a weight gets put on top of your brain, and like you can't think and you can't focus and you can't wake up either because antipsychotic medication. So just a brief rundown of what schizophrenia is, because there's a lot of misinformation out there. So schizophrenia is first and foremost a disruption in the thinking and reasoning of a human being. It's not just hallucinations, it's not just psychosis or any of those things. It's an actual disruption in the thinking and behaviors of a person. So what I mean by that is at the core, you can actually be diagnosed as a schizophrenic without the positive symptoms. So your positive symptoms versus your negative symptoms are what are the keys in diagnosing schizophrenia. So one of the main things that you've got to realize when you're diagnosing schizophrenia is that these aren't a result of something else like drug use or maybe a manic episode or anything like that. So you really do have to make sure that you're diagnosing correctly. Okay, let's go through. I'm trying to remember all the symptoms off the top of my head, but there are a couple of positive ones. Now you might say positive symptoms, that sounds good. No, these are just what positive means in this instance is added, because that's another use of the word positive. So the positive symptoms are additional things that are added to the person's behavior or psyche. So a couple of things are in that list. One of them is the classic one that everybody knows, is the hallucination aspect, is classified as a positive symptom. It's where the person starts to hallucinate or experience voices, seeing things, and in general distrusting the surrounding. The other one is known as delusions, which can be tied into your I'm very sorry about the I've literally got God flying through my window in the back here. So the other positive symptom that many people will know is delusions. Now, delusions is a firm belief that a person has that is not grounded in any reality or anything that can be measured as reality. So things like a common one is believing that people on the television are talking to you directly, like they were a person in the room talking to you or having a discussion with you. That's an example of a delusion. There are several others, and there are some weird ones. So it all depends. And delusions can be incredibly strong. If you believe, if you are deluded in believing that you have cancer, for example, you may feel or exhibit signs that you associate with cancer in your own head, right? So it's a very strong belief. And the problem with delusions is if you challenge a delusion, it often reaffirms that person's belief. So you can't directly challenge a delusion. You can try and get to the bottom of the thinking and try to dismantle it that way. But if you directly attack a delusion, the person's going to become defensive about it. It's a really stronghold belief, just as strong as like you believe that you are a human being, you know, and that when you look outside you see the sky and the sky is blue, therefore the sky is blue. So it's that level of firm belief Same as attacking a core belief. Exactly, Synchronous. So those are the two main positive symptoms, is hallucinations and delusions. Now, delusions, another common one that I hear people talk about a lot, is believing that a person, usually a celebrity, is in love with you when you have never interacted with this person. They believe that they are in love with you and that you are in a loving relationship. There are also a couple of others. One that people may be more familiar with is this is tied into delusions, but can also be attributed to a separate positive symptom. It's the paranoia. So very often a person who's experiencing a psychosis will believe that people are out to get them, their friends, their family, and any small amount of information that they can tie to that, right? So like your friend could say to you something mundane like, hey, just checking in, are you okay today? And you might interpret that as them trying to spy on you and get information from you. So those are the main positive symptoms of schizophrenia. The negative symptoms are things that are removed from schizophrenia, removed from the person's personality. So there's something that you'll probably have heard of already called the flat affect. Flat affect is basically, or negative affect, or blunt affect, is when a person shows no emotion or expression in what they're saying. Oh, there's another positive symptom that I just remembered. I'll circle back to that. I just want to explain the negative affect. So this would be a extreme deficit in the person's motor capability and their expressive capability. So when I say that, what I'm actually referring to is the person may enter a phase of like what would be described as catatonia, a prolonged stage of not moving at all, not being able to move, not being able to think or move. Like, for all intents and purposes, they are stunned. And that can be really, really intense. Some people, before the invention of antipsychotics in the 1950s, their catatonia was so bad that they needed help doing just about anything. So before we read this article, I do want to emphasize that antipsychotics indeed do have their place, but what this article I think is going to focus on is the effects of long-term uses of antipsychotics and whether it's a detriment or a benefit to people with schizophrenia. That's the main talking point that we're going to be focusing on today. But yeah, flat affect and negative affect is pretty common and something that's not often talked about. Like if you've got a friend who's speaking in constant monotone, looks incredibly like completely neutral. We're not talking about a depressive face. Now, you can get negative affect in depression, flat affect, blunted affect. There's multiple different words that we can associate with that. If they are behaving like that, there is a chance that they are going through some form of something that we would attribute to psychosis. Something that we would attribute to perhaps schizophrenia, although you would need a medical doctor to fully diagnose it. So it's actually, and that's the often not talked about symptom, and people are often incredibly abusive to people with flat affect because they believe that they're just being bitchy, or they are, or they don't care about what you're saying and stuff like that. Whereas they might care very deeply. In fact, those who have experienced flat affect, those who have experienced that sort of blunted affect often feel extreme emotions during that time, but cannot express them. So that's what we describe as the negative symptoms of schizophrenia, is those who are unable to process, unable to express themselves at all, to the point where they might even enter a state of catatonia. Now, there are actually two states of catatonia which we should also talk about. That one is actually tied to the positive symptoms, and one of the symptoms I forgot to mention, as a matter of fact, so we're going to circle back to that now. There are two types of catatonia. One is blunted affect catatonia, and the other one is manic catatonia, as I like to call it. It just makes it easier to process, because there's a type of catatonia where... Oh, hey, Rad! By the way, sorry, I'm just busy talking. How you doing, Rad? How you doing, Synchronous? I'm just trying to keep my train of thought going, so sorry if I don't catch the chat as often as I would. All good, love the ranting. I hope that it's more informative than ranting, so to speak. I'm trying to be as informative as possible. May I ask why you're talking about this? Simply because a friend brought it up with me and I thought it would be an interesting conversation topic. I want to do more of a lecture than ranting. I want to talk about more issues like this and bring this into my chat, because I feel like I often have these discussions while playing games, so why don't I talk about them in general as well? Yeah. Do you like my little love emote? I love my love emote. Where was I? Oh yeah, so that you get a sort of another type of catatonia that's actually also found in bipolar people during a manic episode. And this type of catatonia is constant pacing, shaking, twitching, uncontrollable motor responses, speaking, but not actually producing any words that make a coherent sentence, following no line of logic, having no seen thought process, having no connective thought process, so all of the topics are disjointed. And that's also a state of catatonia. It's just a more, I suppose, pronounced one, one that you don't hear about as often. And now we're going to talk about the last positive symptom, although this is probably more tied to the catatonia symptom. But one of the other positive symptoms is called word salad. That is a classic characterization. It's also known as psychotic speech by doctors. And psychotic speech is basically when you string together a sentence that has that seems to have no logical conclusion to it. For the person who's suffering the psychosis, it may make perfect sense, but for a person listening, they won't be able to decipher what they're talking about. So they might start a conversation like, the dog walks to the park and then there was a brown house over on the veranda where the mirrors were and I could see the halos behind me, and lots of chanting about certain lettuces, and they will go on like this for ages, and you won't be able to discern what they're saying. So that's like one of the classic symptoms, and you don't necessarily need to have any of the you don't need to have all of these symptoms. That's why people who don't experience delusionations, that's a word, hallucinations, would be would be surprised that they would be diagnosed with schizophrenia. It's because schizophrenia is more characterized as a thought and a disruption in thought and behavior, right? So you don't necessarily have to have all the symptoms to classify someone with schizophrenia. Now, another thought before we start reading this is what it's going to be relating to. And this particular article is something along the lines of antipsychotics. We're going to be talking about the effects that antipsychotics have on people with schizophrenia. Now, just to understand historically the importance of antipsychotics before we get into this article, that's probably going to grill them a little bit, because it is kind of taking a stance that long-term antipsychotic use is not beneficial to people with schizophrenia. And I do know some schizophrenic people who feel the same way. They feel like their symptoms diminish to a point where they feel more in control, and the antipsychotic medication that they take actually is a detriment to them. They've got a highly sedative state all the time when they'd rather try to be productive. Now, that's not to say you should just go off your meds. There are, I think personally that antipsychotics used in a short-term situation or on a much smaller dose than what they're usually given for people with schizophrenia, just to maintain their thought processes, or the thought processes in that instance, it's probably more viable and will reduce the long-term side effects, because there's a couple that we're going to talk about. I think, let me just check this. I think dyskinesia, dyskinesia is a huge, hey Eric, how you doing? Yeah, so dyskinesia, for those who are on antipsychotics for a long period of time, because of the effect it has on the brain, you can develop dyskinesia, which is involuntary and erratic movements of the face, arms, or legs. or trunk. Talk on a topic on stream. Thank you. So there's a whole bunch of downside. That's one of the major downsides, is it does have an effect on the brain in the long term, with long-term high exposed usage, which we want to try and avoid people having those side effects. That would definitely reduce harm if we could do that in the long run. Now, the importance of antipsychotics can't be understated, though. So, before the 1950s, psych wards were overrun with people with severe catatonia, and with no way to remedy it. They sort of just had to keep them there, and there was nothing that they could really do besides assist feeding for the blunted states of catatonia, and things like that. And when antipsychotics were invented, those symptoms were reduced dramatically, and really started to help those people with those particular symptoms. And they became a staple in treating schizophrenia as well as bipolar disorder, because of those benefits, because it reduced the psychotic aspects of the disease. And then people tried weird things like frontal lobotomies. That was a thing people tried. The history of lobotomies is actually terrifying, and maybe it's something we'll discuss at a later date. But anyway, the point I was Yoda-esque, exactly. So while I'm reading this article, which does One Flew Over the Cuckoo's Nest. Yeah, so it cannot be understated the importance that antipsychotics have had on a variety of people, and have worked in reducing their symptoms. Now, another key aspect of why it's probably bad to have people on these medications at high doses for long periods of time is its effect on the brain. So, for those of you who don't know, antipsychotics do a lot of different things in the body, but one of the main things that they do, besides the sedative effects, is they reduce the amount of dopamine that your brain is producing. Because a lot of positive symptoms of schizophrenia come from a dopamine overload. Okay, and what the antipsychotic does is it reins that in. It reduces the level of dopamine production, which brings down the symptoms, because that's what's causing the brain to be overactive. Because if you don't know, having too much dopamine in your system kind of fucks everything up. So people are too happy, too creative. In regards to what, Zrad? Oh, I see what you're saying. Yeah, so dopamine in high enough doses causes you to detach from reality, and causes things like hallucinations and stuff. It's kind of one of the key things that happens when you take a tab of acid or eat some shrooms, you know? Even when it's a good thing, exactly. Yeah, so it's not being too happy. Put it this way, if you had a vitamin B deficiency and you took vitamin B, it would greatly increase like your level of health and your level of functionality. But if you then decided to take a huge amount of vitamin B because the small amount was helping you, you would encounter adverse side effects like multiple organ failure. So it's really not, it's like the two aren't connected. So you can't be like it wouldn't make you too happy. It would start acting on other areas of the brain. So you see, it's not making you too happy. It's now interacting with other areas of the brain, like your perceptions and your sight and your hearing system and stuff like that. So it starts binding to other parts of your brain that control other systems, because there's not enough dopamine receptors for the excess dopamine. So that's basically how antipsychotics work, is they bring down the level of dopamine, which in turn stops a lot of those symptoms. Now, however, talking about all of that, I do believe that putting patients on such a high dose for a long period of time, even when they aren't experiencing symptoms, can have bad outcomes and bad side effects. So we're going to look at this article and see what it has to say about that. As I said, my friend sent this to me, so I'm not quite sure. I'm not quite sure what the through line is going to be, and we're not going to go through everything. We're just going to kind of skim read it and then see what I can talk about with the article. Although it is widely assumed that there's abundant evidence from critical trials that antipsychotics are effective in knocking down psychotic symptoms over the short term, there's a big hole in the evidence base, as researchers reported in 2017. No placebo-controlled trials have ever reported in first episode psychosis patients. No placebo-controlled trials have ever been reported. Oh, okay, I see. I glossed over that word. This means that there is an absence of evidence for this class of drug in medication in medication-naive patients who have never been exposed to antipsychotics before. Okay, fair. Now, I'll start this off with a little bit of an anecdote. When I was going through a severe manic episode, we overloaded my system with antipsychotic medication, and sure, it brought down the severity of what was going on, and I actually passed out and slept for a night. But it did not. But maintaining that dose did not help in any way. The evidence for the short-term use of antipsychotics comes primarily from randomized controlled trials conducted in hospitalized patients. In these studies, patients on antipsychotics are abruptly withdrawn from their medications, and then after a few days, those who have become actively psychotic are randomized. Whoa, that's a bit of a study within antipsychotic. Researchers then measured the decrease in psychotic symptoms over the next 4 to 6 weeks. Okay, so this is the clinical trials that they did, and we're going to be looking. Okay, in 2009, Lucht, I hope I'm saying that correctly, published a meta-analysis of 38 trials of second-generation antipsychotics and reported a response. That's just standard scientific process. I know, but doesn't it just give you... Yeah, no, it's standard. I know it's standard, but doesn't it give you like the bit of the willies when you read it out loud? That we kind of use people... I know that it's the only way that we can actually learn stuff about this stuff, but it is... You know, I'm sure that the people are adults and agree to it, you know, it's just... just putting yourself through hell just for science is, you know, better than using guinea pigs like guinea pigs. Exactly, I agree. The results nevertheless reveal that the majority of patients treated with an antipsychotic receive no additional benefit beyond placebo and yet are exposed to the adverse side effects of the drug. So basically, I mean, I don't need to explain what a meta-analysis is because it just explained it in here. So if I still need to explain it a bit more, a meta-analysis is where you take multiple studies and conclude from the multiple studies that have been conducted. So of 38 trials, right? Okay, so basically what this paragraph is telling me is that outside of the psychotic symptoms, these medications have very little to no effect on function until there are psychotic symptoms. And in fact, the adverse effects, as shown by these studies, remain. So for example, when I was on a very high dose of antipsychotic medication, but I wasn't experiencing any sort of mania or psychosis or whatever, I know I'm talking about this from a purely anecdotal stance, but I feel like it's useful. I feel like it's helpful information. All that ended up happening is I couldn't function during the day. So like I would wake up, I would go to bed at like, I would try to go to bed at like 10, and then I would wake up at 1 o'clock the next day, and I wouldn't be able to function until 2 or 3 hours after that. So, you know, not the greatest, not the greatest. So I can just say that I sympathize with that analysis. To assess the impact of drug on treatment of all patients, researchers calculate the number of patients treated in NT. In this meta-analysis, the response rate was 41% versus placebo, which means that for every 100 patients treated with the antipsychotic, there are 17 more responders than there would be with placebo alone. The NNT left study was 6. Okay. This means 6 out of every 7 patients. Yeah, so basically this is just giving us the statistics of those versus the placebo and versus the other stuff. This means 6 out of every patient treated with an antipsychotic are exposed to adverse effects of the drug without receiving any benefit from treatment. There's no benefit group composed of those who are non-responders to the drug, 59%, and those who respond to the placebo, 24%. Thus, 83% of patients could said to be harmed by short-term treatment with antipsychotics, while 70% benefit. Okay, so that's interesting, because basically what I was saying is that short-term treatment versus long-term treatment. So in short-term treatment, only a very small amount of people are actually benefiting from that short-term treatment. And well, from what this is saying, and this can actually, yo Rasky, what's up? Hey. And those who don't benefit just get the adverse side effects. So I'm actually friends with people with a lot of people with psychotic disorders, and I found that a lot of them say that when they were on antipsychotic medication, some of them have come off completely, but outside of the short-term benefit it had of reducing their psychotic symptoms, in the long term it gave them severe adverse effects. Yo, stream's dying. Nice. It gave them long-term adverse effects. So things like not being able to concentrate during the day, zero focus, things like that. And time blindness is a huge one. You know, you wake up at 10 o'clock and then by 6 o'clock you're only starting to function, and then you realize it's 6 o'clock. So there's a lot of adverse function to it. But 24% would probably only have 41% response rate if it follows the rates of the non-placebo group, so that 83% number is too high. I know that you're right about, I know that you pulled out a Kalki boy for this, but I'm just going to pull out one. Yeah, I do think, yeah, that number is a bit too high. Yeah, so this is a bit, yeah, you're completely right. I wouldn't have picked up on that math, so thank you. So 83% of patients harmed is not correct. It's a lot less than that. Oops. Yeah. Okay. So we've already found a little bit of a hole. As I was saying though, a lot of people have, it's not huge, but 41% of the red section should be in the blue section. Yeah. Wait, is that red? It's just... Changes the rate, but not really the conclusions. Yeah, I think that the conclusions are still, but yeah, I can see the math kind of failing there. But yeah, so basically what this is saying is that even some people are harmed by the short-term use. So there's a lot of cases, and something that I've seen in psych wards as well, where you get someone who is medicated to the eyeballs, and like literally they just lie in bed the whole day kind of drooling. Like that level of medication is not conducive to healing, I don't think. So I think that's what the study is actually looking at, is that in a big majority of the cases there's a lot of stuff that could possibly be useless. I love it when they do colored graphs and colors that I struggle to see. It's so fun. 2017, Look colleagues published metadata analysis, double-blind. 51% of these patients in these 160s even had minimal response to the antipsychotic versus the 30% placebo group. Okay. So does that mean taking medication is overall bad? No, I think that you have to do it by a case-by-case analysis is what the study is trying to get at. In that it's not always helpful. So so taking medication isn't overall bad. It's just that at times the medication doesn't help, and if it doesn't help, and the patient says it's not helping, then you should probably rethink your treatment strategy. What might be the alternative if it doesn't help? Well, Rasky, for starters, there are more than one type of antipsychotic medication. While they all do basically the same thing, there are other alternatives that can be tried, and they all work in different ways. So that's one of the things. Also, this isn't saying that taking it is wrong. It's trying to argue that on average, in this specific scenario, blanket dosing does more harm than good. Yeah, that's what I'm getting at, Synchronous. I hope that that's coming across. Is that kind of what I'm saying? Is that in my experience, you know, you need to look at an alternative. If it's not working, you need to come up with a different treatment plan. Yeah. Whereas a lot of psychiatrists, I believe, in a lot of instances, are drugging their patients to the eyeballs if they. And in some cases, that's all you can do, right? If somebody is having a serious, severe, and dangerous and like are a harm to themselves episode, then you do whatever you can to reverse that. I mean, a lot of medical treatments work this way, guys. Okay, so like, what medical professionals often look at when they are trying to treat a patient is, will this reduce harm? Not bring harm to zero, will this reduce harm? Even simple things like taking antibiotics, you know, like it does damage your body, but the benefit is that you can fight off the infection better, you know, but it can cause massive damage to like your system because there are some bacteria and stuff that you need in your body. But also in an underfunded public health scenario, sometimes doctors do the best they can with what they have, and it's not always the best treatment possible. That is true. For example, one of the staple atypical antipsychotics, the staple in the private medical field anyway, is Seroquel. And when it comes to Seroquel, the government cannot get access to Seroquel. They literally cannot. So they have to rely on things like olanzapine and Halidol and various other. And I think Zopidem is Ambien. I missed you. I know. Sorry, I didn't stream for the past 2 days. I really do apologize. First of all, my roommate is moving stuff. My roommate is moving stuff in, so I keep getting distracted, having to help her move stuff. And then on top of that, I've been incredibly busy. So sorry, I haven't been around. But yeah, So, like, don't take this article to mean medication bad. Watching you at work, how are you? I'm good, thank you. Yeah, don't read this article. And so my friend who sent me this article has some I shouldn't actually get into their beliefs. I promised I wouldn't mention them on stream, so I'm not going to. But basically, what you should take from this article is that some approaches to some instances are not helpful and in fact are harmful. So from a medical standpoint, you should be looking to reduce that harm. But like Synchronous says, often in a public health scenario, they're doing the best they can with what they have, you know, which kind of sucks. We should have better healthcare. This is going to turn into a rant about free healthcare. But yeah, just from my personal experience, I have seen people get drugged up to the eyeballs, and it's done nothing but harm their function as opposed to helping. I've been drugged up to the eyeballs before. It's awful. Oh, but yeah, what I was saying about reducing harm. For example, one of the common ones that you can actually research and policy changes also take a long time to filter down practices for various good and bad reasons. Yep. Yep. Sometimes things aren't for the better. Are we talking about ADHD meds? No, read the title. Read the title bar. We're talking about antipsychotics and schizophrenia. So when it comes to meds, what you're looking for is harm reduction in a lot of cases. So one of the key examples that I can think of is chemotherapy. Chemotherapy is very bad for you. It's literally radiating your fucking body. But it's trying to reduce the harm that the cancer does to you. It's trying to kill the cancer. So while you might not survive the chemotherapy and you become immunocompromised and your hair starts falling out and you start throwing up from the therapy and all of that stuff, the harm that's being reduced is the cancer, you know, because if the cancer is left, you die. So the alternative is a lot of harm and a lot of taxation on your body, but you might survive the cancer, you know. So that's often, so you see, it's always a harm reduction, trying to keep people alive dynamic when it comes to medication. So just blanket saying that medicine are bad is not good enough. Adverse effects. Although second generation antipsychotics are often grouped together as atypical antipsychotics, radiation therapy is also some gnarly sunburns. Yeah. Which suggests they share a common mechanism of action. These drugs on a number of different neurotransmitter pathways and do so with varying degrees of potency. For that reason, the drugs have adverse event profiles that vary widely. Okay, so basically, these meds do different things and have different adverse effects. A drug's disruption of neurotransmitter pathways may cause predictable adverse events, such as dopaminergic pathways. What? Dopaminergic pathways are involved in control of motor movements. So that's what I was touching on a little bit earlier with the fact that antipsychotics on a whole inhibit dopamine production and dopamine receptors. Which, motor movements. I was talking about dyskinesia earlier. That is a long-term side effect of being on antipsychotics for a long time. Drugs that block dopamine receptors can cause Parkinsonian symptoms, muscle dystonias, and akathisia. These are all things that you don't want. What is akathisia again? I can't remember. Is that to do with speech? Akathisia, or is that aphasia that's speech? I can't remember. In addition, dopaminergic pathways are vital to the normal functioning of the limbic system and frontal lobes. That's why if somebody is drugged up to the eyeballs on antipsychotics, they sit in a corner and sit on their bed and just drool all day. Nice stuff. And thus, dopamine blocking drugs may inhibit emotional responses to the world, a limbic system function, and self-awareness, frontal lobes. Yeah. Aphasia. Yeah, so what is akathisia again? Condition characterized by... this is just motor function again. Okay. Motor function stuff. But it is worth noting that all three of these are different types of motor function disorder stuff. So it's all linked to motor function, but it's not the same in terms of categorizing it. Just so we're all aware. Blocking the serotonergic receptors can cause increase in appetite, weight gain, metabolic change. Yep. This is a huge problem, by the way. This right here, the increased risk of diabetes, with the weight gain and stuff, huge problem. You'll often find people that are on chronic antipsychotic medication will at some point develop type 2 diabetes because of increase in appetite, weight gain, and metabolic changes. This is the reason I gained so much weight, by the way. Because I was on these antipsychotic medications. I'm lucky that that I'm kind of trying to control my weight and metabolic changes. Yeah, the metabolic changes also fuck you up. So this is all true. And the risk of type 2 diabetes cannot be understated. A lot of people who are on antipsychotics have type 2 diabetes. So this is, it's not just I was going to say coincidental. I don't know if that's even a word, but yeah, it's not just yeah, coincidental. It's not just coincidental. There is actually, do you also have diabetes though? No, I don't. I'm very lucky. Or just weight gain. I have massive weight gain and I'm trying to lose the weight now that I'm basically awesome. You seem really adept at all this medical stuff. Have you considered anything like doing medical research or something? I mean, I want to become a doctor, Brasky, so I do a lot of medical reading. I'm not always right though. Sometimes I say really stupid shit. And so on. Each neurotransmitter has its own side effect profile. Yep. So let's look at this quickly. Expected effects from a drug's blockade receptors. Receptor type, dopamine. Extrapyramidal symptoms, weight gain, endocrine effects. Yeah, it also affects your endocrine system, which is not good. Akathisia, we've talked about. Tardive dyskinesia. So this is also a motor function issue. Research is also really boring number crunching and analysis, especially meta-analysis, which is what this is. Yep. So to make an article like this, guys, I'm not kidding. You have to sit and read statistics all day from interesting stuff that other people do. How's that going? Not too well at the moment. I want to book my NBT as soon as possible though. So hopefully I'll be able to book my NBT this year so that we can see if I can actually apply. Because the NBT is going to be very important. It's like writing a master's thesis, yeah, pretty much. Increased prolactin. So this, like, if you are a titted individual, if you have breasts, I mean, you may see an increase in your lactation from certain antipsychotics. That is a side effect. Sexual or reproductive system dysfunction. Yeah, I didn't know about this one. But I suppose if it hits, if you're reducing, if you're having stuff block your dopamine, yeah, I can see that it would lower your libido. It would probably make it harder to get erections and stuff like that. Serotonin, weight gain, diabetes, increased appetite. These are very common, incredibly common symptoms. Histamine. So I didn't know that. Wait, hang on. Is this? Oh, okay. This is actually assessing antipsychotics. Okay. All right. Okay. I just had to read at the bottom here because this could have been a basic table of blockages. So histamine. Histamine is your body's response to certain, what's the word? To external factors. Commonly, we know about histamines because of allergies. So if you're allergic to something, it's generally a histamine response. And what an antihistamine does is it blocks those receptors so that your body starts reacting less to the external stimulus, like dust or pollen or a bee sting, stuff like that. What is an epinephrine actually? Is epinephrine epinephrine's a steroid, right? If I remember correctly. Irritant. Thank you, Synchronous. That's a good way to put it. What's an epinephrine? Epinephrine. Epi is adrenaline. Hormone medication. Okay, yeah. Yeah, okay. So it just pumps your body full of adrenaline. Nice. Muscarinic. Dry mouth, blurred vision, urinary retention, diabetes, cognitive problems, tachycardia, hypertension. Muscarinic. What is muscarinic? What is it actually referring to? Relating to, resembling, or producing, mediating parasympathetic effects. Oh, okay. Okay. Yeah, some of these are pretty common as well, especially tachycardia. You'll find a lot of yo, Nismo, what's up? You'll find a lot of patients with who are taking medications like this with tachycardia. So after they take the medication, they get lots of a deregulation in their heart beats, and also cold sweat and stuff like that. Claritin is a second-generation antihistamine, according to Wikipedia. Claritin, yeah. So the interesting thing about antihistamines is that histamine is essential to a lot of your bodily functions, especially your body's reactive. So it's not all. Oh my god! A fly just flew into my coffee. Fucking stupid fly. I'm still gonna drink it though. Extra protein. I took the fly out. I'm just kidding. Yeah, so you'll find, especially dry mouth, urinary retention I can see being quite common. Cognitive problems, definitely. Adrenergic, I hope I'm saying that right. Postural hypertension, dizziness, syncope. Yeah, I don't know these terms too well. I didn't know about these. Postural hypertension, dizziness. Yeah, okay. This has to do with your adrenal system, right? Adrenergic. Working on adrenaline, epinephrine. Okay, yeah. Yeah, so you do need adrenaline and stuff in your body, by the way. And what is syncope, actually? I'm quite curious. Syncope. Or is it syncope? Yeah, syncope. Oh, syncope. Alright, I've never seen it written before. Okay, I know what syncope is. Yeah, dizziness, fainting, stuff like that. I've never seen it written before, so my brain went to syncope. Yeah. So, like, this is the effect these antipsychotic drugs have. So they're pretty serious, right? Like, especially like imagine you have a whole bunch of medical problems and require antipsychotic medication, and suddenly also then get diabetes, you know? Or you're trying to sleep at night and you're getting massive tachycardia, cold sweats, memory problem. So when I was on a high dose, I'm going to tell you guys a little anecdote. When I was on a super high dose of antipsychotic medication, I had to get up at 6 a.m. because I had a training course, a reptile training course that started at 9 a.m. and I had enough money to pay for the course as well as pay for the trip over there. But they could only pay for the course in cash. So I went to a bank and drew 1,000 rand, which equates to about $80. $80, or like, how many euros? Like 70 euros, 60 euros, 65 euros. And I had a memory blackout and found myself in the shop trying to pull out money to pay for my food, but I didn't have the 1,000 rand in my purse. My brain had gone onto autopilot and removed the card from the machine without removing the money. And by the time I got back to the machine, someone had already taken the money. So I lost 1,000 rand, which was Pretty disturbing. As can be seen in the above graph, SGAs may cause dizziness, array of physical, emotional, and cognitive problems. Yes, the easiest way to conceptualize the risks of an SGA may be to look at the neurotransmitter pathways. It's only $66 or 59 euros these days. Oh, okay. Usually when I get like $80, it's just over 1,000 rand. And what potency we see in which adverse. So these are just a few of the atypical antipsychotics. So that's the what do they call them? Second generation? Yeah, second generation. Risperidone, which is sold under the brand name Risperidone. So is your roommate moving out? No, I'm moving in a roommate. So my roommate is moving in. I've got a really cool queer-friendly roommate moving in. So presume that's $80 before conversion charges. Yeah, probably. That's a good point. Olanzapine, which is also sold under the brand name Olanzapine, if I'm not mistaken. Might be sold under a different name, actually. Let me see. Oh, here's some olanzapine. Ulan's 10. I don't have... And then quetiapine, often sold under the brand name Seroquel. Wife and kid. Yeah, there's a story there. Do you guys want to hear a story? My landlord came into the house and forcefully kicked her out. I don't know what relationship problems they were having, but he literally came in and just kicked her out. Literally. Unfortunately, like, I'm not in a position where I could have done anything about that, because I'm pretty sure, like, literally kicked her. Not kicked her, I mean, told her to leave, and then took all of her stuff and just like, here's your stuff, go. So I don't know what happened there. Figuratively, literally. Yes, figuratively. Why? What about the kid? Not literally, exactly. Yeah, I don't know the full extent of the story, so I didn't want to get involved. Though I'm pretty sure under South African law, I'm pretty sure you can't just forcibly remove someone like that. I don't know if he had a court order or not. I can't, like, I like the place I'm staying, and the landlord has always been very nice to me, so I don't really want to, go and fight that fight. Does that make sense? I wish that I was in a more wealthy position, where I could just be like, hey, I don't think that this is legal, but, you know, I can't. So I don't know what was going on there, but I knew that there was some problem. Yeah, not your battle. Unfortunately not. But I do, I am getting a new... You don't have the bandwidth to get involved. Exactly. And he's always been nice to me, so, I mean, like, that's chilled. Well, it's not chilled. It was a bit of a scary situation for me, to be honest with you. I don't like seeing people get evicted from their house. Surprisingly, that makes me uncomfortable. You know? Just a little bit uncomfortable. Yeah, I'm getting a new roommate, and she's like, like, I could deal with my old roommate. I could deal with her, but, like, she was very homophobic and very, prejudiced towards, well, yeah, she was very prejudiced towards, like, other races and stuff, you know? I don't feel comfortable calling a black woman racist. Lulu was homophobic. No, my roommate wasn't Lulu. My roommate wasn't Lulu. You mean wife? Yeah, yeah, it was a very prejudiced human being. And now I'm getting a queer-friendly, upbeat, very chilled seemingly chilled roommate. So while I don't know what the whole story was with her, so nice. Yeah, there's a positive side to it, but also I can't help feeling a bit distressed that like someone just got kicked out of their place, you know. Like he did everything. He fucking changed the locks. Oh my god, it was a bit of a day. It was a bit of a day. And this is Piprazole, which I think is sold under the brand name Halidol, if I'm not mistaken. And so the way that these things block some sort of empathy, I mean, yeah, I'd be very worried if I didn't care about somebody getting kicked out, you know. But I don't know the full story, and honestly, I don't. Misanthropic Missile, welcome in. Hello there, I'm writing a report for my Harvard class. What's the general attitude of queerities towards the new policy and the workings? The question, queer nudist safe spaces where queerities are able to express themselves freely. What are your opinions on it, and what does chat think? The report is done with polling and statistics. This seems like a ban. So, oh, goodbye. I was about to take that person seriously until I read the whole thing. Twitch flagged as a suspicious account. Yeah, pretty fucking suspicious. I was interested, but like the moment she said, or they, or whatever their name was. I have a light up read. Oh, nice. Thank you, Rad. Well, I'll check that out. I have the light up red highlight for me shows accounts that are less than a week old. Yeah, the moment she said like Harvard study, or they, or he, I suppose they were called misanthropic something? Misanthropic Missile. Yeah, not... the moment I read that I was like, The bot. Yeah, it's probably a bot, that's true. Anyway, I don't want to be stun locked on that conversation. It seemed also did that seem like a bit of a dog whistle to you? Yeah, queerities nude queerity spaces. Did that seem like a little bit of a right-wing dog whistle to you? I don't know. Seemed like a little bit of a dog whistle. I don't know. Just tiny bit. Okay, so this is binding. So what do they mean by binding? So if that was an actual term. No, queerities is kind of like weird. So the way that blockers work is they bind to receptors, or at least in a few cases. To get fucked, yeah. Yeah, sound like, yeah, I agree. I don't know, Synchronous, I'm a streamer, I'm not that quick to judge, you know, but Twitch did flag it as a suspicious account, and what they were saying was garbage, so, yeah. So the way that often, not always, but often blockers, what they do is they bond to receptors, which prevents the actual chemical from bonding to the receptors. So dopamine subtype D2. Subtype D2. I assume that's just the common dopamine in the brain. Risperidone dodges bonds to a hell of them. Olanzapine, very little. Quetiapine, very little. This is why... So you'll notice here that quetiapine actually has the least, you can actually see on the chart, actually has the least effect. And that's the reason that a lot of psychiatrists have actually been using it as a sleep aid for people with depression or anxiety. because it's not as severe as the other antipsychotics. Still pretty high on the histaminogenic, but overall least harm. Okay, so basically this chart just tells us very high, moderate, low, and we can see the different results. It seems like the Halidol one has the most effect, olanzapine being like sort of second. I'm not going to go through all the charts, you can kind of look at them. In short, antipsychotics cause a broad range of side effects: metabolic dysfunction, endocrine dysfunction, motor dysfunction. Yeah, we read all of this. Brain atrophy. This ties into the dyskinesia and stuff I was talking about earlier. The drugs can induce akathisia, an intense inner agitation that's associated with increased homicidal and suicidal behavior. Yeah. If you don't have enough dopamine in your brain, if you're being given too much of a medication and you have a much lower like dopamine count in your brain, yeah, you can probably I don't know about homicidal, but I know about suicidal tendencies being increased by antipsychotics. Over the long term, they may cause tardive dyskinesia, which is what I talked about earlier, which is characterized by rhythmic involuntary. In adults, tardive dyskinesia usually persists even after the antipsychotic was withdrawn. Yep, it's chronic. Once it starts happening, the damage is done. Evidence of permanent damage to the basal ganglia. Let's just remind myself what basal ganglia is. Group of structures linked to the thalamus or base of the... Yeah, okay. So that would... Yeah, basically this is just saying... This fucks you up, yo. Are the nerve bundles. Yeah. This is what causes all the motor dysfunction, by the way. Yeah, so it becomes chronic. Basically the tardive dyskinesia becomes chronic because there's like nerve damage. Together, all of these adverse effects lead to poor global health. Long-term outcomes. The long-term outcomes literature for antipsychotics, which has been compiled over the period of nearly 60 years, consistently tells us that drugs increase the likelihood that a person diagnosed with schizophrenia will become chronically ill. Yep. Also see case against antipsychotics. Okay, so these are all of the meta-analyses. So basically this article is a summary of all of these meta-analyses that were done. Should I move my, oh, I can't move my camera anywhere that wouldn't block. Damn it. I could always just turn my camera off, but I'm not going to do that. Has this paper been peer reviewed? That's what I'm looking for right now, because these are all, this is the meta-analysis of all of these papers. World Health Organization summarized. I don't know, my friend just sent me this paper and I thought it would be interesting to read what it has to say, so I'm having a look now. Okay, so there's a whole bunch of graphs here. Can I see peer reviews, please? Maybe at the top, but I didn't see anything at the top. It mentions peer-reviewed papers, I guess. This is a peer-reviewed paper. Here we go. Yeah, but that's not the same as being peer-reviewed. I know, Synchronous, I know! Because the paper is drawing conclusions itself. Yes, it is. I don't see any... That's a good point. Next time before I read a paper like this, I'm going to check if it's peer-reviewed. I will say that the information it's conveying is not wrong, I don't think. These are all statements that I believe, except maybe we haven't looked at these ones yet. Is this it here? Because usually it would be listed at the bottom, right? Yeah, I don't see anything indicating that this is peer-reviewed. This just seems to be an article. Yeah, I did say that I didn't know anything about MAD in America. I just wanted to talk about this topic. So I kind of just looked at it and thought, you know what? Let's have a chat about this, you know? So I didn't check the paper. I did the reaction Andy thing, Synchronous. I didn't check the sources. I just checked to see if it was an important piece of information to include. Yep. First follow-up study. Yeah, so I'll link this. I can link this paper in chat if you want to go through the references. What is MAD in America? This paper. If you want to read through all of this, because this is basically the meta-analysis. These are the studies that you go through. There's a lot of good information here, though. Also a book. Thank you, Synchronous. But yeah, this is basically the meta-analysis. I suppose we can look at the fancy graphs rather than reading. I'm just going to look at the pictures now. Schizophrenia outcomes, developing versus developed countries. I feel like I'd have to actually read the whole thing. I saw an interesting graph here, so I wanted to see. Long-term recovery rates for schizophrenia patients. Where's this coming from? Does long-term treatment of schizophrenia with antipsychotic facilitate recovery? Okay. schizophreniabulletin.oxfordjournals.org. Psychiatrist. Thank you, Bar. I do try. See, here we go. References, acknowledgements. This is all reviewed. Also, it's published at Oxford University Press, so I assume that they did their work. So we can have a look at this. So the reception on the book is that while the author does hold extreme views, many of the points raised are valuable discussion points that are largely critical of treatment of mental health patients. Yeah, I'm not saying, guys, just for the record, I'm not saying that this is the absolute truth and, you know, antipsychotics are bad and evil and you shouldn't take them and stuff. That's not the point here. The point is that there are instances, quite a significant number of instances, where antipsychotics do nothing but diminish the health of the patients. So while they are useful, they are not a catch-all treatment and stuff. And I know a fair bit of I know a fair bit anecdotally. I know a fair bit of people with schizophrenia and schizoaffective disorder, bipolar disorder, and other stuff, and their experiences are very similar to what this paper is actually getting at. A lot of people who are schizophrenic, most of the time function okay. It's just when their symptoms get incredibly severe that they need to be hospitalized and treated. But most of the time, they're fine. They just live with their stuff. You know? And they actually, a lot of them have said things to the effect of antipsychotics feel like a weight is on my brain and I can't think and I can't focus and I can't function, which is similar to my experience. I can understand that. It does, like, if you're on a significant dose, it does feel pretty awful. Also, like, some of the side effects can be terrible. Okay, let's have a look here. Long-term recovery rates for schizophrenia patients. What are they defining as recovery, though? Okay, so what they're saying is that people who are on antipsychotic medications for a long period of time don't recover from their symptoms as quickly. I don't know how true this is. But it does come from a paper that seems to be peer-reviewed, and in the Oxford stuff. What exactly did they say? Oxford... yeah, Oxford academics. So, you know, there's probably some... But hang on, where did they get the graph from? Did they just make the graph up? Maybe the graph is in the full paper. PDF. Does that paper define recovery? Yeah, that's what I'm looking for. I don't think it does. Because this graph doesn't appear. That's why I'm like, this doesn't, like, most of the information that I've seen in is 16 mentions of recovery. Antipsychotics are also viewed as some of the leaving over a prolonged to facilitate. Yeah, but what do they mean by recovery? Is that defined in this paper? Because recovery can mean a hell of a lot of things. Okay, so this is how they made the graph, by the way. See over here? This stuff is how they made. Keep mashing F3, yeah. They often assess remission rather than complete recovery of symptoms. Okay, so remission is different, okay? Okay, MAD in America, remission is different. Like, it's a form of recovery, but it's not... Okay, with many patients with mild to moderate levels of psychotic symptoms viewed as in remission. Okay, so, like, that's how they're defining recovery, but the way this graph phrases it, do you see why that's a little bit of a problem? The graph is phrasing it like a complete recovery, you know, like, this is so much better without antipsychotics. And actually when you go and read the paper, it's like, seems disingenuous, you know? A lot of what was said in this article I agree with, but this is disingenuous. I agree. This is all from the same patient, from the same thing. Global adjustment of all psychotic patients. I lose some faith. Yeah, I was on board with all of the other stuff it was saying, but these graphs are disingenuous. They're not representing the evidence honestly. So while some of the stuff I agree with, and what they've said does hold some water, this is just anti-psych meds. This is getting into anti-psych territory, which I don't think is good rhetoric. Doesn't mean everything is trash. Yeah, I agree with some of it, but a lot of it is, but these graphs have been misrepresented of the information. I'm not sure if they well, they must have read the whole paper, right, to make these graphs. Like, they can't have just... Because, I mean, I'm not gonna lie, this kind of looks like they're making shit up, doesn't it? Doesn't this kind of look like they're making shit up? Just a little bit. Like, there's no way that this is accurate information. And, like, defining long-term recovery, this is... That's worse, not better. Yeah, that's what I'm saying. Synchronous, that's what I'm saying. So, I don't know. I feel like you've anybody who's like critical of this and seeing where these graphs head would realize that the information is being misconstrued slightly. Also, there's a little bit of bad math here. There's a little bit of bad math, which I didn't even pick up on because I was just reading through it. But there's a little bit of bad math going on here. So, I mean, like, overall, if I'm to be honest, apart from a few little bits of bad math, and definitely, because I'm not interested in anti-psych rhetoric, so I would see this as grounds for an actual study by competent researchers, but I wouldn't see this as proof by itself. Yeah, exactly. Yeah, that's a good way of viewing it. That's a good way of putting it too. Like, if they gave, is this guy a doctor? They're an about. Robert Whittaker is the guy, right? American journalist. Won numerous awards for covering medicine and science. Oh shit, he's a journalist. He must know everything about medical stuff then. Look, I don't want to discredit all the information in here. I think that some of it is really good. But a lot of it seems like this seems fine. I don't know if this is accurate though. Like, did he just make all of these graphs? You see, once you encounter something like this, and then you see the other graphs where you were like, oh, okay, this seems reasonable. Oh, okay, this seems fine. Like, this is fine because this is all stuff that I know to be true. Right, but like, how can I trust this? Can I trust this? You know, this kind of brings everything into question. But yeah, this is like, yeah, this is grounds to do a better study, not a study on its own. You know? Yeah. I think that was good. what do you guys think? Did I cover that subject matter well? I'm still new to doing this kind of stuff on stream, so I hope that I presented what I thought relatively well. What should we do? Should we... I love this lecture. Yeah, this is going up on YouTube, so say hi to YouTube, everyone. Hello, YouTube! Hello, YouTube! But yeah, like just in closing, I feel some of what the study says. I mean, thanks for coming to my TED Talk. I understand some of what's going into this. I think that what the guy was aiming at, this guy Richard Whittaker was aiming at, was that antipsychotics are bad all around, which, you know, that seemed to be his conclusion, which I think is wrong. I think that they help in specific circumstances. Hang on, my roomie's telling me, babes, are you going to be home? I guess, yeah, I'll be home. Just finding out what time. But I do think that the conclusion is a little bit too extreme. It's like saying well, we found that this brain surgery that saves people's lives 15% of the time. Babes. Well, yeah, that's what she calls me. She calls me babes. What time? He eats pork. Like, if it's your only method to try and assist someone, then you should use it. Sometimes it's not going to work, you know? And maybe we'll discover something better. 8. Okay, it's coming over at 8. That's fine, I'll probably be done streaming by then. Julio. But we'll see, because I get really sucked into Dark Souls and want to play Dark Souls all the time. Even while I'm working, I just want to play Dark Souls. So yeah, that's my thoughts on this paper on stuff. It isn't peer reviewed, so you know, it's just a journalist article. That was sent to me by a friend. I do feel that some of the information was presented just disingenuously, either purposefully. I think that there's just a little bit of cognitive bias, you know. Like you look at some numbers on some studies, and then you go, yes, it's exactly what it is. That's how I think of it, you know. Little bit of bias going on there. Whereas if you actually look at the studies are saying, well, this kind of happens when you do this, and then sometimes the antipsychotics will have this effect, but there's also this. Some of it is presented to fit a narrative. Yeah, exactly. Whereas, like, people who actually do the studies are like, you know, like sometimes it doesn't help, but sometimes it does, and we need to sort of balance that, you know, when we look at this and we look at patients, and we need to do a patient-based analysis and a personalized treatment for different, you know what I mean? Like when you read the stuff, they're very careful not to say drugs bad, you know? Because they do help people in a lot of instances. And I feel like, in my opinion, short-term usage of antipsychotic medication can be beneficial, but long-term chronic antipsychotics do lead to some very bad symptoms, some very bad side effects, which we need to address. So that's my take. I'm like they have in sci-fi shows in The Expanse, you just sit on the couch, it scans you and dispenses what you need. Heck yeah, let's do that. Alright, I'm gonna play some Dark Souls now.